introducing the next speaker as well, since cardiac MR and cardiac CT are both related to radiology type of topics, which is something that I do. And the next speaker is also another very good friend of mine, Dr. Johann. He is from the Care Hospitals, and he's the director of cardiac imaging at Care Hospitals. Similar to Priya, Dr. Johann has also been extremely active in the Indian Association of Cardiac Imaging. He's also an executive at the Asian Society of Cardiovascular Imaging. He's one of the co-authors of the CSI position statement in heart failure. Over to you, Johann.
Thank you, Sanjay, for the kind introduction and respected chairpersons. Today, I'll be talking about cardiac CT and heart failure. And yes, the recommendations from the American College is fairly clear that non-invasive imaging to detect ischemia and viability is reasonable in heart failure and coronary artery disease. And it has a 2A with a level of evidence C, which is quite okay because we just don't have that much data. Now, we do have a plethora of options today when it comes to imaging the failing heart. And each one, as you can see, has their own way of depending, and they have their own strengths and weaknesses. And in my role of honor, I would say that echo takes a top spot, and Dr. Satish has really done, validated that ideal. The second place, obviously, would be CMR, and Priya has really done a good job. And the lowly third, cardiac CT in heart failure, I will try to do justice. Now, why would you do CTA when you had two superpowers like echo and MRI? The most important, obviously, would be the role and the evaluation of coronaries, which is obviously the holy grail of cardiology. And I don't think any cardiologist worth his salt would like to look at a patient without first knowing what his coronary status is. But whenever there is a window issue, you would like to look at CT, especially on echo. And if there's a lot of metal artifact post intervention, again, CT comes to its fore. We do believe in the future that CT will be a one-stop shop in the evaluation of heart disease, both looking at the coronaries, the calcium, plaque and stenosis, myocardial perfusion, delayed enhancement, scar, and obviously functional evaluation all in one. Why would you still do CT with such two competing technologies? It's easy, it's safe, it's very quick. It's 5 to 10 seconds compared to an hour of an MRI. The radiations have become much lower, and we are doing sub-millisievert at this point of time with the high-end scanners. Scanners are everywhere across this country. You will find that even in the district level in India, we have cardiac CT scanners, but really no MRIs there. And technicians are, again, a dime a dozen. They just require a little bit of training. And in terms of images, I think Dr. Sanjay, a past president of the Indian Association of Cardiac Imaging, has really taken this forward, and we have been training a lot of people. We do this training twice a year. So coming to heart failure, the first thing that you would like to know is the diagnosis, which depends on the ejection fraction, the volume, and the diastology. And you will clearly see here, and this is a multiphasic retrospective gated scan, showing you very nicely the LV and the RV wall motion. And using the Simpson's technique, we can see a very good illustration of the LV volume and RV volume and ejection fraction. And the data that is available shows that it is fairly comparable with cardiac MRI. Now, RV function has always been the bane of echocardiography, and MRI is known as the gold standard for the RV. And you can also see, if you look at the Bland-Altman plot, that CT is very, very close by, and the levels of agreement is quite near. In terms of diastology, we know that the left atrium plays a very important part, the volume, the size, the change in size of the LA from systole to diastole, and cardiac CT can depict all these. Now, there's a paper from Korea which has really looked at an accurate evaluation of the diastolic filling pressure compared to tissue Doppler imaging. And they found by the evaluation of the mitral annulus and the movement of the mitral annulus in systole diastole and the movement of the apex, you can have a fair idea of the diastology. Shifting gears to etiology of heart failure, and we know that heart failure is a big basket of multiple etiologies, from idiopathic to sarcoid to amyloid, and we need to have a technique that can really look at all of these. But if you look at Felker's data, we can clearly see that heart failure is basically two things. One is secondary to ischemic heart disease, which we have been traditionally evaluating by a coronary angiogram, a normal coronary angiogram on the left and an abnormal one on your right. However, we believe that cardiac CT is well poised to take over that role, and the power of zero is a very, very important and good prognostic indicator. In our lab, 299 is an important marker to detect a positive stress test. What is more important is the power of quantification of atherosclerosis, which is lacking in coronary angiograms. The normal CTA is a very reassuring site in heart failure. It comes about by a very non-invasive way, low radiation, 10-second scan, and the specificity and sensitivity is anywhere between 97 to 98%, and the images are quite pristine. Yes, you also do have patients with severe calcification, severe triple vessel, showing you that this is a case of ischemic cardiomyopathy. If you look on the panel to the left, you will see that this is a case of a right coronary occlusion with a inferior wall infarct, and the one on your right shows an LAD infarct with an aneurysm, clearly showing you the depiction of regional wall motion with the CT being quite stellar. Coronary evaluation with new software again is excellent, and the evaluation of stenosis is almost near FFR CT levels at this point of time. We do have patients who have multiple stents, and you can see the stent imaging using very specific iterative sequences is very nice, and you can actually look through the stent and have a very good idea of the stent stenosis. And this is a patient with heart failure with a focal in-stent restenosis in the LAD stent, and this is in the RCS stent, clearly showing you the precise nature of the CT. In our patients post-bypass, coronary CT is a very, very valuable tool. It does this examination in 10 seconds, minimal contrast, and you get a pristine level of the graft patency and clearly ruling out graft occlusion as a cause of heart failure. With hybrid techniques, you will see that the addition of the SPECT here clearly shows you a significant ischemia in the LAD diagonal area, which is there on stress, which becomes normalized on rest, clearly showing that ischemia has to be taken care of in this patient to avoid the progression of heart failure. And if you look at the data from SPECT CT and MACE, you will see that if you have an abnormal CT and an abnormal SPECT, the MACE is extremely high compared to a normal CT and a normal SPECT, very good for prognostication. We have been doing some work on myocardial blood flow in a dual source Siemens scanner, and these are perfusion maps showing you the decreased perfusion in the LAD territory and the aneurysm over here. SCAR is again well seen on CT, almost nearing the precision that you get on MRI. And again, this is a patient with an LAD scar. Moving on to the non-ischemic heart disease, aortic stenosis, again, is a very important valvular pathology that we're seeing. And what is lending itself to be important is the availability of TAVR, which is huge in the United States and gaining traction in India as well. Right from the evaluation of the valve, the calcification, the annulus, and also the rest of the aorta, especially the access sites and the access route, and also the level and angle of angulation, CT has become a gold standard for patients to undergo TAVR. In patients with aortic regurgitation, especially those secondary or dilated aortic route, CT again provides a lot of information on the annulus, on the ascending aorta, on the sinuses, and also gives you as a bonus the coronaries as well, and avoids you to do an invasive angiogram. Aortic aneurysm, again, evaluation is very, very pristine on CT, and whether you're doing a percutaneous approach or a surgical approach, the evaluation of the aneurysm size and is extremely easy on CT. TMVR, again, is an emerging technology, and we're just seeing a couple of them in India, and CT, again, gives itself to excellent rendering of the neo-LVOT and the mitral valve annulus evaluation. Now, we are also seeing significant cases of RV dysfunction with the tricuspid regurgitation, and we know that the tricuspid valve does not lend itself to intervention in more ways than one. So a very useful way of plugging the SVC and IVC and preventing the tricuspid leak from going above using the trick valve is a very, very important tool that is now coming to fore. And CT is very exquisite in creating a virtual map of the SVC, IVC, and the RA, and also for the very myriad measurements that are required for the SVC and IVC valve placement. We talked about ECV on MRI, and cardiac CT is not too far behind, and this is work from a Japanese group showing you that you can do a pre-contrast CT and then a 6-minute delayed CT, and then you can develop a subtraction image and use that into the volumetry and then develop an ECV map based on the LV volume. Dilated cardiomyopathy, again, we have seen is very well seen on echo, and you can do the same on CT. The left atrium, the LV geometry can be easily assessed and measured. But what is important is an underlying severe coronary artery disease can be evaluated at the same sitting. When it is added to PET, CT plays a very big role in the assessment of disease activity in patients with sarcoid, and also the place where a biopsy can be done. And when you start them on immunosuppressants, and we see this patient 1 year later, complete absence of disease activity, very good for follow-up of these patients. Pericardial calcification and pericardial thickness is very exquisitely seen on CT. In our country, with tuberculosis, pericardium is a seat of disease, and it's very, very easy to evaluate it on CT. In patients with right heart failure, one of the most important things is rule out a pulmonary thromboembolism. And this is a case of a bilateral thromboembolism. But what is even more important is that if you have an RV dysfunction, there is a 3 times higher morbidity, mortality. And the RV evaluation is very exquisite on CT, provided a slightly different configured sequence is used, wherein you have contrast in the right side and the left as well. And we have had some very good images from there. In patients with tumors, especially involving the aorta and the LA, again, before you send them for surgery, an accurate evaluation of exactly where they're arising from, where they are moving, and also the coronaries are important, and CT has a role to play in that situation as well. Moving on to the treatment of heart failure, we know that there are 3 major treatments that we look at, and one is AF ablation, the role of CRT and LVAD. And in AF ablation, making of the left atrial maps and the pulmonary vein maps are very important in order to target them for the pulmonary vein ostial ablations. What is also important is the location of the esophagus in relation to the pulmonary vein, because that is the seat of a major complication that can happen. And also accessory pulmonary veins can be located by this technique. But we are going a step further, and we are trying to now register these CT maps, especially into the electroanatomic maps with CARTO. What is important in the sequence and very important to tell the patient is to hold the breath in expiration and not inspiration, so that the maps turn out to be very accurate when you register them in the live CARTO, and helps the interventionist to cut down the time for fluoro, cut down the time for ablation, and also prevent the complications that arises. And this is a lot of data coming in from Seoul as well. LA occlusion devices, again, initially there was a role of echo, but with TAVR gaining traction, now CT is slowly becoming the new kid in the evaluation of LA occlusion devices. And again, ruling out a LA thrombus is very, very easily done on CT. Now, CRT, we know, is important in patients with heart failure, severe LV dysfunction, dilated left ventricles with an LVBB, and in QRS more than 140 to 150. But what is important is we know that there is almost a 20% non-responder rate in these. And one of the things that we have seen in our series is that the evaluation of the coronary veins are extremely important, and anomalous coronary veins or low origin of coronary veins can be easily assessed on CT before the patient goes onto table, and also if there are valved coronary veins, so that you have specific devices, specific leads that can be used. Also, the presence of scar, which is again, as I already showed you, available on CT, then you could go for a decopolar catheter, not a unipolar, and that helps us in pace the ventricle at that point. If we use a unipolar catheter, then the sensing may not be as good, and this is one of the reasons for non-responders. Now, in the same regard, there is data showing you that you can do a CT and you can cleave out the cardiac veins and then superimpose the 3D echo map on it, which is also showing the dysynchrony, and that does it very well. And then seeing the dysynchrony areas, you can map the coronary veins and actually personalize and choose the exact coronary vein, which will help you get the best reduction in the delay. Our family of LVADs are now increasing, as we know that the heart failure population is increasing, and most of them cannot get a transplant, and therefore LVADs have really increased, especially in the metros. And this is a patient who has had an LVAD, and you can see it for assessment, the inflow catheter, the outflow catheter, the presence of thrombus, the presence of a malposed inflow can also be seen. The other problem is with the addition of so much metal, the RV function is not easy to be seen. So that can be assessed also with CT. In transplant patients, we're now beginning to get more of the coronary vasculopathy, and this is a patient who has a mild lesion in the LAD about a year after the transplant. And after 2 years, you can see that because of the immunosuppressants that are used, there is a focal stenosis in 2 locations, and CT is a very good tool to follow up these patients. However, there are contraindications for CT. The true contraindications obviously are atrial fibrillation with fast ventricular rate. We have had some successes with atrial fibrillation with controlled rate, and although there are some artifacts we're able to do with them, but a fast rate is clearly a contraindication. Any patient who cannot hold breath for more than 6 seconds, again, will lead to a very suboptimal scan, and it's better to choose some other technique. There are some relative contraindications which more or less as experienced operators we've been able to overcome, which is the high calcium scores, patients with contrast allergies, high heart rate, renal dysfunction, and morbid obesity. In conclusion, CT is an important tool. It's ranked 3rd in the honor list, no doubt. But in specific situations, it can be used to diagnose heart failure, differentiate between etiologies of heart failure. It's a very quick, non-invasive, easy scan to look at the heart and the coronaries. And the holy grail of cardiology, we believe, is coronary evaluation, and CT does a great job. And in the new family of devices that are coming in, like CRTs and LVADs, I think cardiac CT has a great role. Thank you very much for your kind listening. And I truly believe that CT is going to be the one-stop shop for imaging. Thank you.